Welcome everyone to the Long COVID Web webinar. This is Karen Chow. I'm the director for Long COVID Web. And today, very delighted to welcome everyone to our monthly webinar series. So first, I would like to start with our land acknowledgement. We wish to acknowledge this land on which the Long COVID Web operates. For thousands of years, it has been the traditional land on the Huron Wendat, the Seneca, and the Mississauga of the Credits. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. Just a recap of the purpose of the Long COVID Web webinars. This is a session that we want to share evidence-based information, research results relevant for decision makers, researchers, clinicians, patients and families, and the general public. To provide ongoing updates, spotlights on emerging evidence, and scientific information about the activities of our national network, and also to contribute to reducing and managing misinformation about long COVID. And just a reminder of our code of conduct. There's a link to our full code of conduct at the bottom of this slide. We highly value engagement around the science and its interpretation as well as application. And we're committed to reasoned discourse as stated in our code of conduct, and comes with a responsibility for all to ensure that any comments or questions remain within the spirit of positive, constructive, and respectful discussion. And we welcome any or all questions and comments in this spirit. And just a bit of housekeeping. The camera and mics are all off. And please post your questions in the chat. This can be done during the presentation, and we will pause for Q&A after each speaker. And for today, we're actually going to do that at the end of the session, as the three speakers are going to have one presentation. We will do our best to review and address as many questions as possible, and some of them might be answered directly in the chat. And these sessions are recorded, so your attendance assumes consent to recording. And with this permission from the speakers after this webinar, this might be posted online following the webinar series. We welcome your thoughts about how these sessions could be most helpful. So we will be posting a short link. It's a very short survey, and we want to have your feedback. So you can feel free to click that link and provide your feedback. And if you are still not a member of Long COVID Web, please feel free to click on our website, join as a member, so you can stay updated on this series and also some other information that's sending out by our monthly newsletter. Okay, so without further ado, we're going to start today's session. We're joined by Dr. Douglas Gross from University of Alberta to facilitate the Q&A session. And now turn that over to our three speakers today. Kelly O'Brien from University of Toronto, Jessica DeMars, and Helen Skiffington from Long COVID Physio.
Can I get a thumbs up whether people can see the slides? Perfect. Thank you, Karen. Thank you, Doug. Thanks to Long COVID Web for the invitation, to Jessica, Helen, and I to share with you some updates on some of the current landscape related to disability and rehabilitation in the context of long COVID. And we want to also acknowledge the collaborations with Long COVID Physio, Rehabilitation Science Research Network for COVID, and the Department of Physical Therapy, where I am situated at the University of Toronto for this work as well. So in today's webinar, we hope to highlight and share with you some recent findings from a research study to establish a conceptual framework of disability experienced by adults living with long COVID, as well as the role for safe rehabilitation in order to address that disability and embedded within that to describe some of the lived experiences, perspectives, and to also share some practical resources for clinical practice and research throughout. The World Health Organization defines long COVID as a history of probable or confirmed SARS-CoV-2 infection that usually occurs 3 months from the onset of COVID-19 with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. There are a number of different symptoms associated with long COVID, and these may be new onset following initial recovery from acute COVID-19 or persist from initial illness. And a key feature of this definition is highlighting that these symptoms may fluctuate or relapse over time. More recently, the National Academies of Science, Engineering, and Medicine provided a definition and characterizing long COVID as an infection-associated condition that occurs after SARS-CoV-2 infection, again present for at least 3 months as a continuous and relapsing, remitting, or progressive state. Accompanied in this definition are a number of further details to describe different aspects of the condition. And Anne Barrer from Long COVID Web has provided this wonderful schematic that encompasses the spectrum of long COVID symptoms and how they may be experienced. Each of these broad categories of symptoms may be represented by the gears in the schematic. Each of them can combine differently and interact with each other, further complicating the clinical presentation of long COVID. Adding to this umbrella or other post-infectious conditions such as ME/CFS, dysautonomia, and others that can frequently increase the burden of symptoms. A common characteristic across these definitions are highlighting the multidimensional, multisystemic, and potentially episodic nature of health challenges. Here, as a quick recap of the prevalence in Canada, an estimated 19% of those who have had COVID-19 experienced symptoms for 3 months or more. And of those, 2.1 million are still continuing to experience symptoms as of June 2023. 42% of those experience symptoms for a year or at least a year or longer, and roughly 22% are experiencing symptoms that limited day-to-day activities and resulted in missed work or school due to symptoms. It is estimated that approximately 100,000 Canadians have been unable to return to work or school attributed to long COVID symptoms, highlighting not only the social but also economic impact of long COVID. There have been some excellent review articles that really characterized comprehensively the mechanisms and multisystemic nature of long COVID, characterized by over 200 symptoms or health challenges, and really highlighting the heterogeneous, multisystemic, and multifaceted nature of long COVID that can change over time, as well as the discrete pathological processes with overlapping phenotypes, which again can make difficulties with presenting when it comes to clinical or presentation in clinical research. So collectively, these health-related challenges in the context of long COVID may be referred to as disability. And this relapsing or remitting nature of disability may be characterized as episodic disability. And this is defined as any health-related challenge that may be experienced by an individual that can fluctuate either on a daily basis, within the course of the day, or on the longer term of living with the condition. So we set out to determine to what extent the concept of episodic disability is characterized or experienced among adults living with long COVID. We conducted an international community-engaged qualitative research study involving over 22 team members and 5 community organizations in Canada, the UK, Ireland, and the US. We conducted a series of interviews online with 40 adults living with long COVID in each of the 4 countries, asking them about their health challenges and their impact on their overall health. Among the 40 participants, the median age was 39 years. The majority were females. 83% were living with COVID for a year or longer. The majority had experienced relapse in their symptoms, and a half were unable to work at the time of the interview. This honeycomb figure here articulates the terms in which the participants in this study described their episodic or fluctuating or relapsing and remitting aspects of their health challenges living with long COVID. Overall, the participants in this work characterized the concept of episodic disability as a continuum of health challenges that involved variable presence, severity, and duration of health episodes. Disability was not an all or nothing concept, but rather it is a continual state of health challenges experienced over time. Disability is multidimensional. It can include visible but also invisible dimensions, some of which may be episodic, while others may coexist with permanent or more stable aspects of disability over time. So collectively in this work, we've put together something called the Episodic Disability Framework. And this was originally derived in the context of HIV, and we set out to determine to what extent this framework may align or fit with experiences of adults living with long COVID. And this framework includes 3 components. The first is dimensions of disability. So these are the health challenges that experience as a consequence of long COVID or other concurrent conditions. Contextual factors, so things in the environment or intrinsic to an individual that can exacerbate or alleviate health challenges or disability. And third, triggers, which are momentous events that can spark an episode of disability. And for more information, you can click here on the QR code to access the preprint article of the details of what I'm going to speak about next. So this figure articulates one potential exemplar of what an experience of episodic disability might be like. Each of these colored lines represents 6 distinct dimensions of disability, known as component A. And within these large fluctuations in health and disability over time are the daily fluctuations, or good days or bad days, or good or bad moments within a day that may fluctuate over time. Component B, or 2 of this framework, are the contextual factors. So these include, in circle, the intrinsic or individual factors, or extrinsic in square or environmental factors, which in green may alleviate different dimensions of disability or exacerbate dimensions of disability over time. And lastly, components 3 are the triggers, which are these life events that can exacerbate or spark a particular episode of disability. Focusing in on the physical symptoms, these are some of the examples of the physical impairments or health challenges that were articulated by the participants, which you can see here span a number of different multi-systems in the body. There are cognitive health challenges as well that span cognitive endurance, difficulties with executive function, concentration, memory, information processing, and multitasking. Mental and emotional health challenges articulated by participants included stress, anxiety, or depression, fear, anger, experiencing mood swings or irritability, as well as feelings of guilt or loneliness. And it's important to mention that many of these emotional health challenges were a distinct consequence of living with long COVID. Difficulties with day-to-day activities included mobility, transfers, ambulation, walking, dressing, meal preparation, cleaning, as well as attending appointments. And challenges to social inclusion included activities engaging with others. So this might be initiating or maintaining personal relationships, engaging in employment or school, labor force participation, and the disruption that came from that living with long COVID, and sometimes the financial uncertainty that may result, or the disruption to or loss of certain retirement goals or plans. And the 6th and final dimension of disability was this uncertainty and worrying about the future, as participants described how they sometimes worried about what their future might entail, the sometimes unpredictability of their episodes, unpredictability of triggers, and worrying about their long-term health and recovery potentially with long COVID. And this often impacted life decisions such as return to work, family relationships, and the consequences that might entail over time. So moving from the dimensions of disability, now to the second component of this framework are these contextual factors. And these are the things that can exacerbate or alleviate different dimensions of disability over time. Over on the left here in the squares are those extrinsic or environmental factors. In green include practical, emotional, and social support from friends, families, partners, pets, community, agencies, and networks, as well as support from accessing environment and health services. Some of the a contextual factor that may exacerbate disability, such as stigma and epistemic injustice, may be experienced through the form of gaslighting through our health system, for example, which may exacerbate a dimension of disability. Some of the intrinsic contextual factors, including personal attributes such as sex, gender, age, race, ethnicity, pre-existing concurrent health conditions that may exacerbate or alleviate disability. And then a huge component of these contextual factors include what we've called as living strategies. And these include attitudes, beliefs, outlooks, behaviors in which individuals adopted, sometimes in their day-to-day lives, in order to try to mitigate dimensions of disability. Some of that included seeking out support from others, seeking out knowledge, many from community-based organizations about long COVID. And a key aspect from this work and the interviews was pacing. A number of participants in this study talked about how pacing was a helpful living strategy in order to manage their symptoms and avoid potential crashes, but were very clear to articulate that pacing, while a strategy, was not a cure for long COVID. The third and final component of the episodic disability framework are these triggers of disability. And these were moments, stimuli, or events that could initiate or exacerbate an episode of disability over time. Some of the examples here in this slide include a reinfection with acute COVID-19 or experiencing an exertion, either physical, cognitive, or mental in nature. This slide here highlights two illustrations from participants. At the end of the interviews, we asked individuals to draw what their experience of episodic disability has been like living with long COVID. And here you can see elements of the exacerbations of disability and how that might align over time and from initial infection, as well as potential reinfection, characterized as spikes or clusters of symptoms. And on the right-hand side, how there are elements of unpredictability with this episodic nature. So a part of moving forward or improving in health, but there's also a part of moving back as well. So in summary, this episodic disability framework is a way in which to conceptualize the experiences of adults living with long COVID in this study, including dimensions, contextual factors, and triggers of disability. This provides a way in which to better understand the experiences of adults living with long COVID and can help to advance measurement of how we go about measuring or describing disability and areas in which to target future health or rehabilitation interventions and services, which highlights my passing of the baton over to Jessica to talk about the role of safe rehabilitation in addressing disability in the context of long COVID.
Great. Okay. Thanks, Kelly. And thanks in advance for being the slide advancer as well on this. So what I want to do is highlight where maybe we seem to be at with regards to safe rehab for long COVID, and where we need to be, and maybe some suggestions as to how we get there. So next slide. I gotta advance mine on this side. So this was the study that was done at U of T in 2023 with the students there that Kelly kind of helped facilitate. And really great study looking at exploring the experience of physiotherapists in Canada working with adults with long COVID. So next. I'm just going to kind of pick out from this poster because it's a lot of information. So when we provide the slides to this, you'll be able to kind of go through it more there. So next slide. Basically, there was uncertainty about long COVID in terms of its pathophysiology trajectory and how to treat it. And through these semi-structured interviews, it became clear that there's variability in physiotherapy approaches to long COVID. Some carried on with graded exercise, as they would in other conditions, while others reevaluated their traditional methods and sought out safer rehab approaches. So we know that there was kind of this mixed bag of things going on. Again, this was around 2023 to get the sense of what was going on. 4 main recommendations came from participants, and I really want to just highlight the one that's kind of really relevant to today's talk, and it was around education and training of physiotherapists and the need to integrate long COVID specific education into school curricula and continuing education. And I really think that this last point is key to getting more consistent safe rehab for people with long COVID. So next. So there's indeed providers out there who are knowledgeable and practice safe rehab. We know that they're out there, they're doing great things, but we also know from patient experience that this is not consistent. So a couple of individuals that I know, I asked them to share their experiences, and my disability insurance through my employer insisted on doing a functional assessment for my return to work recommendations. I was not even close to returning to work. I was referred to a large rehabilitation clinic that was well established in many provinces. I was assessed by an exercise therapist and an OT. The recommendations were a 3 times a week physio program, 2 hours in the gym, 1 hour of mental health counseling, and 1 hour of OT to support with ADLs at home, plus travel time of 30 minutes both ways from my home. Some days would amount to 5 hours with therapies and travel time. So again, kind of fitting individuals into that box of our traditional return to work. Another individual, it was quite early in my journey, lead physiotherapist saw that I had me lifting 5 pounds of weights, but was still just clutching at straws with zero information. At that time, masks were still required, but he refused to use one. So again, we're not really practicing patient-centered care at that point. So I started seeing his colleague who was more specialized in neuro support, but still had me lifting 1 pound weights. And after one session, I couldn't use my hands for 5 days. So again, just kind of highlighting that gap in knowledge in terms of, maybe trying to do their best, but not having that information at hand. And I know both of these experiences were early on, and I know that it is getting better out there, but we still have a lot of gaps. Next slide. So I think that looking at this, where there's kind of 3 basic steps to integrating safe rehab into practice. And the idea is to highlight that this shouldn't be that difficult to bridge this gap to where we are now to where we want to be. So 1, we have to update our knowledge. We have to understand that long COVID and other infection-associated conditions such as ME are not the same as many of the other injuries and illnesses we in rehab will treat. We cannot fit them into pre-existing programs, which unfortunately continues to be the case, again, with many of these larger return to work-based programs. We need to then integrate continual screening and monitoring, which is key when we look at what Kelly was speaking about in terms of that episodic illness. Individuals might appear fine one day, but are bedridden the next. You screen them out the first time, doesn't seem like there's an issue, but as you get weeks into treatment, hey, things are going sideways. We need to be able to continually monitor and reassess things from that perspective. And then lastly is implementing both of these 2, points 1 and 2, and combining that with evidence-based practice and do that in that clinical setting to focus on patient-centered and safe rehab. Next slide. So step 1, updating knowledge. There is so much free information available. This is just an example. There's some paid courses out there, all sorts of things that are available for rehab professionals to basically upskill. How do we recognize, assess, and treat individuals with long COVID and other infection-associated illnesses? I still hear from my colleagues that they don't see people with long COVID, but as Kelly pointed out in her slides on prevalence and the burden of long COVID, it's highly likely that nearly everyone has come across someone with long COVID in practice, but unfortunately they may not recognize it as such. So I think if we can keep pushing this idea that the information is out there, it's available, we can get more and more rehab professionals aware and on board with safe rehab principles. Next slide. Wouldn't be a long COVID talk if we didn't talk about post-exertional malaise or post-exertional symptom exacerbation, because it really is that key part of updating our awareness and information for informing rehab professionals on safe practice. I've discussed this a lot, but one thing I've noticed popping up recently is the idea that post-exertional symptom exacerbation is a symptom in and of itself. So you'll have this list of symptoms and then post-exertional symptom exacerbation. And it really isn't the case. It describes a physiological response to triggers that result in a worsening of any of all symptoms. So your triggers can be physical activity, could be emotional experience, could be cognitive functioning, it could be the environment, it could be a change in medications, it could be a diet. Basically, there's a lot of different triggers that are out there that we know and some we don't know. And what it does is it triggers a worsening of any or all symptoms. So rather than listing out that, okay, this person is experiencing joint pain and some shortness of breath and also post-exertional malaise or post-exertional symptom exacerbation, we have to look and see, are those other symptoms actually within that bubble of post-exertional symptom exacerbation? Just clinically, for one, I will actually see people with cough whose cough gets worse after they have triggered an exacerbation, right? And that may not be what people are thinking about. Next slide, please. So that second step, that continual screening, right? Long COVID has a high prevalence of post-exertional malaise, post-exertional symptom exacerbation. It has a high prevalence of dysautonomia POTS. It has a high prevalence of exertional desaturation. And things to be aware of is with an episodic, unpredictable illness such as this, is that you might screen this on day 1 and everything is fine. But did you screen it again on day 10, right? Have you looked to see what your interventions are doing for that individual in front of you? So some people may get worse. Next slide. And this is a really great table from Physios for ME, so available online, but like looking at how physiotherapy can trigger post-exertional symptom exacerbation. What parts of your assessment and intervention, right? So your subjective assessment can be a cognitive trigger. It could be a sensory and emotional trigger, depending on where you're at. Positioning of the patient, objective assessment. So you're asking the patient to go through some physical tasks. Yes, that's going to potentially trigger that. And then again, your treatment, exercise, passive stretches, manual therapy, even providing advice, you need to constantly be reviewing how did that patient respond to that intervention. Next slide. So some screening tools that are out there, the Pulse Symptom Questionnaire to help you at least recognize the existence of post-exertional malaise. Functional capacity questionnaire. Really, I like that one because at least the best of what we have right now to describe the impact of doing activities on your daily life. Dysautonomia has a number of options: NASA lean test, Compass 31, orthostatic intolerance questionnaire, Malmo POTS. All of these are readily available, so we can use those. Next slide. And then again, basically, it comes down to just asking the right questions, asking your patient what's happening. Does it take more than 1 day to recover from your usual baseline from activity? Do you feel way worse after doing things? Asking those questions and thinking to yourself, does that fit like a normal clinical picture? Is that something we would expect? So having these conversations, again, backed by that understanding and that upskill and knowledge that you've kind of hopefully been building up. So next slide. So patient-centered care, really, it just means that we have to throw away our pre-existing expectations and bias. And this is really important because individuals are getting a whole lot of normal tests. So we can easily lapse into thinking that this is anxiety, deconditioning, patients' fear of moving, any of those kinds of things. So we really have to get rid of that pre-existing bias, which we shouldn't even have in the first place. Being open to adjusting and adapting to that episodic, unpredictable nature of long COVID. So this means that despite our best intentions and an individual's best efforts, people may still get sick or sicker or get worse. And we have to understand that that could happen. We change our role from the fixer to more of a coach. So we're helping guide management strategies according to each individual and what their wants and needs are and functional goals. So that, and then finding strategies that are personalized and mindful of individual response. So again, the example that I'll throw out here with that is that there is an exercise program for POTS. It's controversial, it doesn't work for everyone, and it certainly doesn't necessarily fit into the context of POTS and long COVID. So we need to recognize that. We need to say, okay, well, here's something, but how could we change that up so that we are mindful of what's going on with this whole person in front of us? Next slide. And this table comes from a paper that was highlighted from a discussion at the safe rehabilitation for long COVID at the Long COVID Physio Forum a couple of years ago. And we kind of summarized our talking points. And again, just kind of highlighting everything that I've just discussed, really, right? That we, our 4 main points are that we're avoiding acute events and symptom flare-ups, aiming for symptom stability. We're creating personalized care. So we should be flexible and tailor our rehabilitation to the needs of the person in front of us. We should be facilitating those expectations. And so we should be aware and helping people understand that this is episodic. What's a realistic expectation? And going from there, what we don't need to be doing is saying, well, most people get better in a year, because that simply isn't the case. So those words should be removed from any kind of treatment program. Psychologically supportive. So we need to be non-judgmental. We need to validate what individuals are telling us. We need to believe our patients. Next slide. So just kind of a proposed rehabilitation pathway, if you will, just kind of recognizing perhaps those clinical phenotypes that we would see. There's more than just the 3 that are on this screen, but I would say from a rehabilitation perspective, kind of these are the 3 big ones. So recognizing those clinical phenotypes and noting how, one, they may overlap. So if you have that kind of post-exertional symptom exacerbations phenotype, you could also have dysautonomia part of it, joint hypermobility, MCAS, I didn't put it on there. So all of those things, we would have that post-hospitalization ICU cohort, but they could also still have dysautonomia and post-exertional symptom exacerbation. And that's where that monitoring comes in. We're doing that all the time throughout the rehab process. Next slide. So what are the challenges of this invisible illness, this episodic illness, and our future direction? So I think identifying long COVID in clinical practice is the first one. So it's a broad definition. So can we identify those phenotypes, recognizing there's overlap, recognizing that there isn't right now kind of that clinical diagnosis biomarkers, but also recognizing that there are many conditions out there that do not have biomarkers that we treat and we work hard to treat. How do we capture the impact of post-exertional symptom exacerbation without causing post-exertional symptom exacerbation? I'm sure that's like $1 million question in this population anyway. How can we objectively measure brain fog? And again, this is something that Helen's going to talk about a little bit in terms of that cognitive piece to it. So these are just some things that I know I struggle with clinically. How do I capture this in my clinical notes? What do I write down? How do I communicate this to insurers, things like that? So those are more questions I don't have answers to, but I'm going to throw them out there for everyone else. All right, thanks. I'll pass the baton over to Helen.
Hello, everyone. Thank you, Jessica, for that great talk. I enjoyed that and was nodding along quite a lot. So I'm Helen. I'm an occupational therapist from London in the UK. And obviously, I'm going to try and talk about the role of OT. And through that, I'm going to try and link it to my lived experience. So I thought it might be helpful just to hear a little bit about me, just for context. So basically, long story short, before March 2020, I was fit and well, enjoying my life. I just got my sort of dream neuro rehab job that I'd been working sort of most of my career to get. And then 2 weeks into that job in March 2020, I got COVID and never really recovered from it. I have multiple health issues as a result of that, including POTS. And then since reinfection last year, I've also had multiple blood clots on my lungs despite blood thinners. And I think work was a big theme for me. I really tried to hang on to work, bounced in and out of work more times than I can even count. Lots of reasonable adjustments, lots of phased returns, reduced my hours, changed my job, changed specialty. But after my reinfection last year, I really deteriorated and my contract ended in March of this year. And obviously at the moment, I'm still too unwell to work. Oh, sorry, next slide, please. I forgot. So the main thing I want to talk about, obviously, is the role of OT in long COVID. I'm sort of going to talk about just the key things that I want OTs to know. I feel like as a profession, we have so much to offer to people with long COVID, but at the moment, there's sort of not a lot of talk about it. I think we need to make a bit more noise, and obviously, please feel free to correct me if I'm wrong, but that's definitely sort of what's happening in the UK, that not a lot is being done OT-wise for long COVID. And we can help with so many different aspects. So we can help with energy conservation, we can help with equipment, and we can help with rehab, including cognition. Oh, sorry, next slide. I don't know why I keep forgetting. So cognition is like a real bugbear for me at the moment in long COVID. Again, I think it's quite often overlooked and it's quite often brushed off as brain fog, when I really don't believe that it is brain fog. As someone with long COVID that's also an OT that's specialised in neuro rehab, this is like cognitive dysfunction, cognitive impairment, and it's actually quite minimising to use the term brain fog when it has such a significant impact on people's lives and ability to do things and fulfil meaningful roles and maintain their job and careers, and also the potential mechanisms that are contributing to the cognitive dysfunction are quite significant, sort of serious things. They're very much basically the same as the potential mechanisms that are driving long COVID. So, for example, viral persistence and the vascular side of things, but there's also neuroinflammation, structural changes to the brain, and cerebral hyperperfusion. So, as Jessica mentioned in her talk, POTS and dysautonomia is really, really common in long COVID. So, posture and being upright is going to affect cognition, because we need effective blood flow to our brains for our brain to work effectively. So I think that's also a key one, maybe, that we can all keep an eye on, because it's a bit, I was going to say, easier for us to manage. It's not a cure, but I can't really do much about structural changes in the brain, but I might be able to do a little bit about cerebral hyperperfusion. Yeah, thank you. And PESE, so again, just to emphasize that it's not just physical exercise or physical energy that causes PESE. It's all of it. It's cognitive, it's emotional, it's sensory. And actually, in a study in the UK last year, they looked at people with ME, and I think they went to their homes and asked them to do different tasks. I think it was having a wash, walking downstairs, and a cognitive task, and they found it was actually the cognitive task that made most of the participants exceed the anaerobic threshold, which just shows how the cognitive task can be more draining than the physical side of things, yet it's so much harder to manage and is often also not really, sometimes not considered. And I think for me, I really underestimated PESE and the effects of that on me. And I think it was partly I didn't know that much about it, probably a bit of denial. And I think I was just trying to stay afloat, that it was sort of just too difficult for me to try and have the energy to try and understand it, because it is hard to identify because of the delayed onset and the fact that sometimes that changes, the way it presents changes. And I have so many other symptoms anyway that they sort of all overlap. But I tried to go through my old diary from when I was working to try and find a pattern. And so this was when I was working. And so you can see I would start the working week okay. So I rate my days every day as a good day, a bad day, or okay day. I haven't had a good day since January 2023, I don't think. But my weeks would start off okay and then would just go into bad. And actually at work, Thursdays and Fridays at work, I really wouldn't enjoy them. They were really difficult. My colleagues and I would actually call them my wobbly Thursday, because I would just be so exhausted, so overwhelmed, in pain. I would quite often burst into tears driving to work because I knew that I just felt so awful, and I knew that I was going to go to work and make that worse. And then I would rest over the weekend, things would get a bit better, and then the whole cycle would start all over again. So that's why it's so important to try and identify these patterns, that we can try and put things in place to resolve them and make things a bit easier. So if I was seeing people with long COVID as part of my assessment, I would be asking them about post-exertional symptom exacerbations. So like Jessica said, asking those right questions, and digging a little bit deeper, because some people might not even realize that they have it. And also, as she also said, it changes. So it's important to just keep asking that question. Also asking about the orthostatic symptoms. So are things more difficult when you're upright and things like that? And obviously our bread and butter, asking about daily activities and routine, and trying to find out where that gap and sacrifice is. So I think for a really long time, people underestimated how ill I was because I was working. So they would just ask me if I was working, and I would say, well, yes, but I've got all these adjustments in place, I've reduced my hours. But they would just hear work, and it's like, great, we need to keep you working because that's what we do. And actually I wasn't doing anything else. My family was doing everything else for me, and in my free time I would just be resting so that I could go back to work again, which isn't sort of the normal healthy sort of functional routine. So again, as well, if I look back, I kind of wish people told me that actually I needed to stop working, but people don't do that. So I think that's also important for people to know. And obviously I know that people just can't stop working, but I think it's definitely worth having those conversations. And then obviously asking about cognition as part of assessment. So asking about cognitive symptoms, and also really helping people to understand what we mean by cognitive symptoms, because people don't necessarily know everything about cognition. A lot of people just think it's memory, and it isn't. It's attention, it's concentration, it's processing information, it's language, it's decision making and problem solving, all of those things. And also being aware, especially for OTs, if you do a cognitive assessment and it comes back as like a normal score, it doesn't mean the person doesn't have an issue. It just means that the test wasn't sensitive enough to detect that issue. So it might have been the wrong test. I think people with long COVID would probably need higher level cognitive assessments. but also being aware, as we've discussed already in these presentations, that sometimes in long COVID, the symptoms can be episodic. So it might be that you caught that person on a day that their cognitive symptoms weren't that bad. And also people often rest for appointments. So you might be seeing them at a point where, again, those symptoms aren't that bad, but if you saw them tomorrow, they'd be really bad. So it's important, if you do a cognitive assessment, to sort of follow up with them and ask them how they felt afterwards, because that might give you more information than just the assessment that you did. And obviously any appointment, including cognitive assessments, are probably going to lead to PESE. So you might need multiple sessions to help pacing. And then obviously with PESE, helping people to identify those patterns as well as part of the assessment. And then as intervention, obviously we can help with equipment, so like a shower chair and things like that. And then it's looking at those daily activities, trying to work out those patterns of PESE, and then doing what we can to avoid them, which normally involves pacing. As has already been mentioned, pacing isn't a cure or a treatment, it's sort of just a way of managing. But also, I want to emphasize that pacing is really, really hard. It's probably the hardest thing I've ever had to do. And I'm an OT and I've spoken about pacing for quite a long time. So if I find it difficult, I can only imagine that people that don't really know that much about it will find it even more difficult. And lots of people have said to me, oh, you just need to pace yourself, as if it's nothing. But it's actually really, really difficult. And it basically just means constantly sacrificing and constantly saying no to things, but that you actually want to do, and having to completely change the mindset that we've all sort of been raised. We have to be productive and we have to be busy. And also society sort of telling you you're a terrible person because you're not doing all of these things. So it's quite a lot to get your head around, which obviously isn't true, by the way. I just want to say that. But it's difficult to just completely change when also really you don't want to be doing it. And I think cognitive pacing is even more difficult to implement than physical pacing. It's hard to pace things that you can't see, and that you don't even sometimes realize that you're doing it or exerting, because it's your thoughts. So you can't like half your thoughts. Well, I can't anyway. I don't know if other people can. But so it's also looking at strategies that might help people. So that, say, I use lots of lists on my phone, and like reminders and things, so that I try and do that to like offload my brain, so that I don't have the added pressure of trying to remember all of these things. The only issue with that is that I now have a lot of lists, so I'm trying to find a way around that. But it's strategies that I think OTs can help with. And I just wanted to flag up some studies at the bottom. And I have to give a shout out to Kira Breen, who's an OT in Ireland and part of Long COVID Physio. I don't know if she's watching, but she sort of sent these my way. And it's about occupational science and how we view time and speed and the relation with occupation. And they did a really nice qualitative piece where they talk about pacing as well. And they refer to tempo. And the sort of tempo refers to sort of our physiological state and biofeedback, and that sort of relates to using heart rate monitoring as a strategy for pacing. And then positioning. So with regards to POTS, it took me a really long time to work out that just being upright, not only, and by upright I just mean sitting with my feet on the floor, not only does it just make me not feel very well, but it also is exertion for me. And having my feet up, I'm much more comfortable. And I think it does help cognitively too. So I'm not saying it's a cure, but obviously it's helpful to try and get as much blood going to my head as possible, to help cognitively. So I think OTs can sort of help equipment wise with that, especially in a work setting as well. If you're in an office or sitting, that can be helpful. And then OTs, I think, can really help with return to work recommendations. So Realise produced this a couple of years ago, and it sort of emphasised the need for reasonable adjustments and sort of extended phased return. And I think that OTs can really help with this, but there also needs to be sort of a shift in thinking of employers and organisations, because OTs and health professionals can make sort of all the recommendations they want, but we need employers to understand and implement these for it to be effective. And oh yes, and sorry, I forgot my own slide. So this is a bit of a messy slide, but that was kind of the point. So I've tried to implement the framework that Kelly was talking about to me, and I just wanted to make a point that people with long COVID sort of carry a lot with them all the time. And I think when health professionals are sort of dealing with a particular sort of group of people, sometimes they sort of just get used to hearing things and hearing about it. But I don't think it should sort of, that we should sort of lose sight of what is going on with people with long COVID. So the green boxes are the physical sort of symptoms, the pink is cognitive, purple is emotional, blue is the daily activities, red is the challenges to social inclusion, brown is the uncertainty, the green circles are what help, and then sort of the red explosions are like are bad triggers that can flare things up. So it's a lot to carry. And then this is a graph. I tried to do a graph. It's probably not as good as the ones used in the study, but my physical symptoms, so although they're always have quite a high symptom burden, they do go up and down, sort of depending on external triggers, so like working and reinfections. And then this slide is sort of the same thing, but it's my cognitive symptoms, which are also sort of going up and down depending on other things that are happening. And then, oh yeah, and that's daily activities, which go up and down alongside the physical and cognitive symptoms. And then when we put it all together, you can see they sort of go up and down together, but the brown line is uncertainty, which for me remains pretty high the whole time. I'm usually feeling uncertain about something. So the green circles represent intrinsic things that have helped me, so like pacing and acceptance. The green are extrinsic things, so I'm really lucky. I have a really good consultant, I have great family support, and then my last manager was really supportive. And then the red squares are things that exacerbate, like gaslighting from other health professionals and colleagues. So in summary from our presentations today, the disability in long COVID can be episodic and multidimensional, and also invisible quite a lot of the time too, which makes it quite difficult. But uncertainty is sort of a key feature throughout. So we all need to work together to try and find solutions, and rehab professionals, we need to learn about PESE and implement safe rehab. And please think cognitive dysfunction and not brain fog. And then we'd like to thank the organisations that support our work. And then a big thank you to the long COVID and episodic disability team who completed that research and put that framework together. And thank you all for listening. And I think it's time for the Q&A.
Yes, thank you very much, Helen. Thank you, Jessica and Kelly. Excellent presentations today. Thanks for sharing your expertise and your experiences. There have been some really good comments and questions in the chat. I've kind of directed them to the individual who was speaking when they came out, but any of you can feel free to speak to these. I want to start with a question for Kelly from Sue Birch. Hi, Sue. Sue says, this is impressive work. I'm stuck on using the term episodic, which by definition implies periods of wellness. Why did you select the term episodic? Progressive or fluctuating don't seem to fit as episodic. I'm sure you chose it carefully and really wants to understand.
Thanks, Sue. That's a great question. Yeah, so the term episodic, and specifically episodic disability, was originally derived in the context of HIV. And this goes back to my PhD work, where I did a series of studies with adults living with HIV to explore their experiences of disability. So I think, you know, the concept of episodic is really not an all or nothing concept, and not to think of disability as disabled or not disabled, not to think about episodic as wellness or illness, but a continual state in which there are various dimensions that make up disability. And the episodic nature refers to the fluctuating presence or severity or duration of episodes of disability that may happen over time. So one can have, for example, in Helen's slide, which I thought really nicely demonstrated the overlap of dimensions of disability and those severities, but even something like uncertainty, which was articulated as more present and potentially more static, could still be potentially episodic, even if it fluctuates within the course of the day or over the course of the week, but it's always there. So I think it's a really good consideration and thought for the way in which we characterize the term episodic disability, to really carefully indicate that it does not mean it is not an all or nothing concept, and it is quite complex and individualized depending on what one's dimensions of disability might exhibit over time.
Thanks, Kelly. Jessica, I think that you might be best to answer this one. There's actually, it came up a couple of times, once from Crystal in Alberta and once from Susan Brown. How can a patient use this information to obtain disability benefits or resources through Canada Pension Plan Disability? Experience having difficulty getting that. Do you have any ideas on how to communicate with CPPD that long COVID is episodic and that attending rehab is not necessarily going to return someone to being able to function in the workplace?
Oh, Doug, if I had the answers to this one, right? This is the one that I probably spend the most time on. And a lot of my communications to disability and insurers are like, here's where this patient is at functionally, and here's what we know so far about this like condition and other conditions like this, in terms of, I just try to educate those third-party insurers as much as possible. Now, obviously not with CPPD, because I'm not like speaking to anyone there. But I guess that it's to try to capture as best you can the impact on your life. That's why I like that functional capacity 27, because at least it's something. But like your journals, like, hey, if I do this, then this happens. But this is the challenge with documenting this, because everyone is stuck on objective measures. What can this person do and what can they not do? And again, in order to test that, so a lot of people will go through functional capacity evaluations. Well, you might be able to do that, but then you're in bed, or you're experiencing post-exertional symptom exacerbation for 2 weeks later, and now you can't shower, you can't cook, you can't do these things for several days or weeks. How is that captured in that one-day test? That one-day test looks like, hey, you've done it all. So these are the difficulties, and I guess the thing to do is to try to find providers. Again, my other side project is to try to create a network of providers where you can go to have someone on board that can help you articulate this, help you capture this in ways. So I don't have a really solid answer for this question, because it is really black and white, and I think it requires a lot more advocacy in this space to try to make those changes. Like, I guess I look at it to, how are we capturing migraine, the impact of migraine? Like, what are we doing? Like, that's, again, one of those things that doesn't have that distinct biomarker, can be episodic in nature, can be debilitating, but how do we capture that, right? So maybe we look to something like that. I don't know. I don't have the answers. I wish I did.
That's a really complicated and huge question. It's probably worth having a session on its own, right, around that question. Question for Helen from Susan Brown. With regard to sensory symptoms, where can a patient access sensory modulation assessments or evaluations, and which medical discipline or allied health discipline can provide guidance or treatment?
That is a very good question. Again, not sure how well I'm going to answer it, but sensory issues are really, really common. Health professionals that can help with it, I mean, I'm biased because I think OTs can do everything, but I would say OT. I don't know if there are anyone else, but it's also what I found recently. So I've had chronic migraine and I'm looking for glasses that can help me with lights, because when I'm at home, I wear sunglasses, but I don't really want to, when I have a hospital appointment, I don't really want to go to hospital appointment wearing sunglasses. And it's actually charities. When I sort of looked on a group, so like there was a sight loss charity that actually had a lot of information. So sometimes it's those organizations have a lot of useful resources that you wouldn't necessarily think of when you're looking for it. But apart from that, I don't really know. I don't know if Kelly or Jessica have anything to add on that, because I know I haven't really answered it. But it's a really difficult question. It's a huge problem. Again, it's one of those, I think, that probably isn't being taken seriously enough.
Thanks, Helen. I noticed that we're 1 minute after the hour. So I want to be respectful for people's times. There has been an evaluation survey posted in the chat. If everyone could take a moment and fill that out. I've got a little bit of time. I don't know about Kelly, Jessica, or Helen. I mean, can we keep answering a couple of these questions? Yeah, okay. One from Nandini Raj. For children and adults living life with long COVID, the majority of safe rehab is symptom management, not really directed at root causes. There's a lot of international research that has been confirming key biomarkers, a lot of the physiological explanation for the symptoms. How can the world of physio or rehab generally collaborate more fully with the medical or clinical community to support management of long COVID? And I don't know who to direct that one to. Anybody want to speak to that?
Well, yeah, I typed in a little answer there, and I guess my point is, we as rehab professionals are always doing symptom management. We are very rarely treating root causes. So whether it's long COVID or asthma or arthritis or even tendonitis, like those have, we are there managing symptoms and function. So that is our scope of practice. Our scope of practice is management. It isn't necessarily treatment. We can't say, well, I think there's some clots here, you should take this medication. We can't do that. We can work collaboratively, and we should be working collaboratively and interdisciplinary with other health professionals. The issue is that, yes, the research is showing these biomarkers. Unfortunately, it's going to take an incredible amount of time for that to be implemented into practice, and in Canadian practice, I would say, because it's going to require a lot more studies for that to then be in there, like in typical clinical practice. And maybe some of the other researchers and clinicians can speak to that, but that's my understanding of it. So it's kind of like, this is what we have to provide. We can provide the symptom management. And I always say, I'm sorry that it's limited to that. That's all that I can give you. But unfortunately, within our scope of practice, that is all we can do. Ideally, we'd have teams created of various healthcare members working together. That would be in a perfect world. But the reality is, right now, those teams are actually being disbanded and losing funding. So those have existed, and now we are losing them. So this is a really unfortunate part of the reality, is that I'd love to have all of that. I'd love to be able to use stuff that's being found in the research right away. I think everyone would love that, but that's my 2 cents. I don't know if someone else wants to comment as well.
I will just add, in terms of a plug for networks such as this, like Long COVID Web and the Rehabilitation Science Research Network for COVID, which are really bringing together researchers, clinicians, persons with lived experiences, policymakers, community organizations and networks to try to, I think, more quickly mobilize that knowledge. I would agree with you, Jessica, in terms of the role of rehabilitation. We are really focused on the health-related consequences of the condition. With that said, it's very important to know what the source is and the root cause, because I think that obviously helps to inform how rehabilitation professionals approach in addressing, mitigating, or preventing that disability.
Thanks, you both. Can I squeeze in one more question? I think it's pretty important. And then there'll be time for you to address any of the comments or questions in the chat that you would like to speak to. But Amanda Risk asked this question: what are the results of recent clinical trials on rehabilitation for long COVID, including possibly the integration of pacing? So just to all of you, are there any recent results that you think have been impactful, or anything that you would like to highlight here?
I can't think of it specifically, but I'm sure that there's research that shows that using heart rate monitoring as a strategy for pacing helps, but that doesn't really apply to rehab. It was just the only one I could think of, but that does seem to help people. I don't think it helps everyone, but it does seem to make a difference. So trying to keep your heart rate below a certain level and not going into your anaerobic threshold can help fatigue. But from a rehab point of view, I'm not really sure. Kelly and Jessica might be more helpful.
So I think with respect to physical activity and exercise, I mean, there are randomized controlled trials in the context of long COVID, in other post-infectious conditions such as ME/CFS. I think, and there are guidelines, the safe rehabilitation guidelines with respect to the World Health Organization around the harms of graded exercise therapy for people with long COVID experiencing PESE and PEM. I would say, when reviewing the literature, one of the challenges that we're faced with is the variability in the definitions of long COVID. So when reading that literature, it's really important to look carefully at the definition of the target population and the inclusion criteria of the participants in that study, and how were things such as withdrawals or loss to follow-up managed, and are they described? Because it might be this work was done at a time before we know what we know now. And so investigators may not have been measuring or evaluating. Like to Jessica's point, it's really important to continually evaluating PESE and PEM. So I would say when reading that literature, it's been a real learning curve for me, and I would say many of our rehabilitation professional colleagues in navigating that literature.
Okay, thanks very much. I see that there's some comments that we need to wrap up soon. But I want to be respectful of people's time. But I also want to thank you. I want to thank our presenters here today, Helen, Jessica, and Kelly. Thanks so much for sharing your time with us, and thank everyone who attended. This session has been recorded, so it will be posted on, I believe, on the Long COVID Web. There'll be a link sent out to everyone that registered. And thanks, Karen. Any last words?
No, thank you so much for all the speakers and Doug to facilitate. I look forward to seeing you in the next webinar. Thank you.